Okay, thank you so much, and welcome back after lunch and learning about CML, and I'm not sure what else. I only caught the CML part. So this talk is kind of a transitional talk in the sense I'm covering two topics. One is about supportive care, and then the other is about what to do somewhere between maintenance and the search for new treatments that will deal with relapse and relapse refractory disease. And so I'm going to start by talking about supportive care, focusing primarily on bone disease. And so obviously, I showed this slide already, we're focused on the specifics of bone disease and myeloma, which you're familiar with. The first point to make, which is very important, is that the treatment for the myeloma, of course, has a huge impact on the control of myeloma bone disease. And this hasn't been looked at possibly as carefully as it needs to be, but with the advent of the novel agents and the novel combinations, as we control myeloma in more patients and to a higher degree, if we have a VGPR within the first 2 or 3 months, there's much less reliance on specific bone therapy if we've already rapidly controlled the underlying myeloma. And so that there is actually increasingly less reliance upon the management of the bone disease per se when we have a much better anti-myeloma therapy to offer. But nonetheless, we do need to focus on patients who have had bone disease occur at the time of presentation and in the early part of their disease. So radiation therapy, just to emphasize that we prefer not to use that except if there's pain, compression, and to prevent threatening fractures. But really, it doesn't help the integrity of the bone at that site. Although you do get rid of an active plasmacytoma that's causing pain, you may actually impair the ability of that region of the bone to heal, and certainly you wipe out the bone marrow which is in that area. And so, if at all possible, it's better to avoid even localized radiation therapy. You may need to use orthopedic support, but try to avoid the radiation. The use of support for the vertebra can be achieved by one of 2 methods, both of which are available widely now. The first is vertebroplasty, with the direct injection of cement into a vertebrae to provide stabilization and to reduce pain. What has become a more popular technique in the US is to use the balloon kyphoplasty technique, where you can recover some of the normal height of the vertebra by expanding the balloon and recovering the shape of the vertebra prior to introducing the cement and recovering strength in the vertebra. And so this is really quite a helpful way to both treat the pain and recover some correction of kyphosis. But the main approach, obviously, to overall improvement of bone and myeloma is the use of the bisphosphonates to reduce the likelihood of skeletal-related events, and this is recommended for all patients with documented bone disease, although with the result of the recent study from the MRC with Gareth Morgan as the lead author, in the study that he presented at ASH, the bisphosphonates were evaluated across the board, including 30% of the patients who did not actually have documented bone disease at the start of the therapy. And so there is a reevaluation of the use of bisphosphonates even in the setting of no documented bone disease. But certainly, I think that most myeloma physicians and investigators would focus on the documentation of myeloma based on lesions present on X-ray, and so this is the gold standard as a baseline to initiate bisphosphonate therapy. Positive findings on MRI or a CT PET scan can show lesions, and there are some criteria for that. Greater than 7 MRI lesions in studies from Barlogi indicate a higher likelihood that there will in fact be destructive bone disease, and a high SUV plus bone destruction on a CT indicates bone disease in that testing. And one can look also at NTX as an indicator of bone destruction. So there are different guidelines that have been published. The Mayo Clinic, the IMF, we published guidelines, and there are also the ASCO guidelines. And these relate to the crucial aspects of bisphosphonates, starting the length of the treatment, the choice, whether you need to consider renal issues and or the osteonecrosis of the jaw dental problem. So first of all, the duration of the bisphosphonates. We started off with open-ended use of iridia with no stopping point, but now with the risk of, particularly of osteonecrosis of the jaw, there have been recommendations that include considering either to stop or to go to a use of quarterly or less frequent bisphosphonates after 2 years, and even the possibility, if there is no active disease, to consider stopping bisphosphonates even after 1 year. And so this is something that has occurred in the absence of clear data to justify differential benefit or side effects with 1 year, 2 years, 3 years, or whatever. And the 2-year cutoff is really somewhat arbitrary. The consensus is really that looking at the likelihood of skeletal-related events, there is no statistical difference in terms of the benefit from pamidronate or zoledronic acid. However, there is definitely some higher likelihood of toxicities, particularly osteonecrosis of the jaw, with the use of Zometa. However, as I'll show you, with proper awareness, that doesn't necessarily have to be such a higher or different risk. One of the advantages is obviously that iridia is given over 2 to 4 hours versus 15 to 45 minutes for the Zometa, which can be a significant advantage in a busy clinic. This is just to show you the nature of the problem in the jaw. The osteonecrosis of the jaw is truly a bone-destructive process that occurs underneath the teeth, and so the first manifestation can be loosening of the teeth or the development of lumps or swelling or irritation at the site of dead bone which has not been destroyed by osteoclast activity. So the first manifestation is the lack of bone equilibrium, where the osteoclasts have been shut down completely and have failed to remove remodeling of the bone areas, and little spicules may pop out of the gums as the dead bone persists and is not removed by osteoclast activity. One of the studies that indicated the potential use of a 2-year cutoff was actually, this was a survey that was conducted by the International Myeloma Foundation and ended up getting published in the New England Journal back in 2002, I think it is now. And this resulted from calls that came into the International Myeloma Foundation back in 2000 and 2001, where patients started to complain of pain and difficulties that turned out to be osteonecrosis of the jaw. And so we decided to do a detailed electronic survey of myeloma patients, which ended up involving about 1,600 patients. This was a comparison of the subset where we could compare the time to the onset of osteonecrosis of the jaw in patients who were receiving iridia versus Zometa. And the important thing here is that the iridia, the likelihood of getting osteonecrosis with iridia is much lower, and it also is much more delayed. With Zometa, it is more likely and also starts to occur much sooner. And you can see actually that 2-year cutoff is quite pertinent related to Zometa, because that's where the curve starts to go up and the numbers get to be above 5%, in that 5 to 10% range. And so this has led in the intervening years between 2002 and now to several changes in bisphosphonate use management. The first thing is that we now recommend that all patients have careful dental evaluation right at the start of the therapy before you initiate bisphosphonate therapy, and get any major dental work done before you start the bisphosphonates. And obviously now, since we do have very good treatment for myeloma, it's frequently not so urgent that you necessarily start the bisphosphonates immediately. During bisphosphonate therapy, it's important to have dental care checkups, but obviously to avoid removal of teeth, because that is the major intervention that actually triggers osteonecrosis of the jaw. And if there is established osteonecrosis, to give supportive therapy for that, which can include use of antibiotics, which can be quite helpful to shut down inflammation and infection, which is associated with the necrosis process, and to use minor procedures to remove the little dental spicules, which can be so problematic, and other types of supportive care, even use of hyperbaric oxygen to try to promote healing. One very encouraging thing is that with the introduction of those kinds of careful strategies, the group in Greece, Demopoulos and his colleagues, Dr. Turpos, they published a very nice paper in the American Journal of Oncology, where they showed with the introduction of these strategies, you can dramatically reduce the problems with osteonecrosis using Zometa. They had a very high rate of osteonecrosis of the jaw, which started off at 16%, which dropped to 5%, a major change just with the implementation of the precautions. But the whole aspect of use of Zometa has become more interesting and controversial with the presentation and almost simultaneous publication of the Zometa trial results from the MRC by Gareth Morgan, presented at ASH and simultaneously published in The Lancet in December. And this was a large study involving close to 2,000 patients, where for 2 treatment regimens, an intensive regimen and a less intensive regimen, there was randomization for patients to get supportive care with either clodronate, which is an oral bisphosphonate available in the UK and Europe, versus the Zometa. And the tantalizing piece of information was that whichever way that Gareth looked at the data, there was a survival advantage for the patients who were randomized to get Zometa versus clodronate. This calculating out to be a median of 5.5 months with Zometa versus clodronate. And this was an advantage where with different statistics, it was overall survival, progression-free survival, in addition to the reduction in the skeletal related events. But exactly in that same issue of The Lancet, one of our colleagues, Dr. Vincent Rajkumar, wrote an article where he discussed some of the caveats about this trial as to how we should be looking at these results. Should we all be giving our patients Zometa, and should we be keeping them on Zometa forever? And so he actually raised what I think were some important questions about that suggestion. One is that this was not a comparison with pamidronate, so we don't exactly know the difference between Zometa and iridia. The second is that in this study, as I mentioned, about a third of the patients actually didn't have bone disease. The second thing is, and you need to look carefully at the published results to see this, is that the survival advantage occurred early, that the survival in the patients receiving clodronate dropped sharply within the first 4 months, and following that, the curves of survival were parallel all the way out to the end of the survival curves. The second thing is that the average length of administration of the Zometa was actually only 1 year. So this particular study did not address the issue of the length of the Zometa. The survival advantage occurred early and was associated with an average 1 year use of Zometa. So it does raise the issue of whether or not patients should be taking Zometa versus Iridia, although they are not directly compared, but it really doesn't suggest that patients should stay on this treatment indefinitely. There was a hope that we could avoid osteonecrosis of the jaw using some other different strategies, and this drug here, denosumab, was the white hope for the future to treat bone disease and to avoid osteonecrosis of the jaw. And this is a rank ligand inhibitor, so that it works in a little different fashion than the bisphosphonates, which attach to the site of resorbing bone and inhibit osteoclasts in that fashion, and are retained within the bone. There was a hope that since denosumab was an antagonist and was not retained in the bone in this fashion, then there would not be that persistent effect that would result in osteonecrosis of the jaw. But it turns out that there was an equal amount, 4.6%, I think, osteonecrosis of the jaw observed with the denosumab study that was published recently. Unfortunately, the data in the myeloma part of that trial was not sufficient to justify FDA approval for denosumab in myeloma, and so there's a larger study planned that will assess the particular benefit of denosumab in myeloma. In the meantime, there are a number of things that can be considered to help with myeloma bone disease. I think one of the more important is that both Velcade and Revlimid are active in the bone microenvironment. Velcade actually enhances osteoblast activity, and Revlimid does have direct anti-osteoclast activity. So the VRD regimen, not only does it have a 100% response rate, but actually could be pretty good treatment for bone. So that's important to consider. So it's important to have plans for bone, and it involves the use of bisphosphonates and also activities for bone to strengthen bone. As far as other supportive care issues, I just want to touch on these briefly before I move into the strategy for relapse and lead into the area of new drugs. The main thing that has happened with regard to the use of the EPO products is that, as you're aware, there has a linkage between the use of EPO not only in the likelihood of getting DVTs, but possibly reduced survival. And so there are dramatic restrictions on the use of EPO now, and really only approved in combination with active cytotoxic therapy. And in the US, you can only use the EPO products now if you take an educational course to make sure that you know what you're doing. In the other areas, we really don't have time to go into a lot of detail, and you're familiar with some of the supportive care measures that we often have to use in patients with myeloma. But for the last part, I just want to touch on a few things which are important about relapse management and the use of new drugs, which will be the closing aspect of our discussions about myeloma this afternoon. And so this slide really summarizes the landscape for myeloma today. We've talked already this morning about the drugs which are approved for myeloma dating back to the 50s and the 60s. The ones in yellow over here are the ones which have been approved more recently, including obviously Revlimid and Velcade. And then moving into the four drugs that I've listed here at the top, which look to be the most likely to get near-term approval by the FDA, carfilzomib, pomalidomide, elotuzumab, and different HIDAC inhibitors. And these are the ones you're going to be hearing about in a moment. And so we've been very, very fortunate to have a rapid escalation in the approved and potentially available drugs in this last decade. But what is the focus of current attention is how to put the pieces of the puzzle together. And you've already heard about different mnemonics of VRD, CyBorD, VTD, MTP. How do you put the pieces of this puzzle of myeloma therapy together to get the best results? And I think that this is the best way to think about it right now. We really do not know the best combinations or the sequencing of these drugs to get both the best short-term responses and long-term improvement in overall survival. And of course, what we're going to be talking about now is maybe we just need one other piece. Maybe one other piece is going to be the one that will make the difference. I don't know if it's going to be varinostat or panabinostat, which you just heard about. I think that Bob is shaking his head at the front. That's not going to be the key piece. I think that, there's a piece that I'm not aware of yet that maybe will be the key piece that we need. And we need to look and scan around and see which area might be the most fruitful. For my 10 cents, it seems to me that I've been talking and hearing about vaccines for 30 years, but I still don't have one that seems to make a difference. So I wouldn't be putting my money over here. I think that we need to be looking for therapeutics, whether anything to do with genetic approaches will make a difference. I'm not so sure. But I think that what is definitely the case is that we have a yardstick now, which is not cure. I really don't like to talk about the fact that we're curing myeloma, but we do need to have some kind of a yardstick that we're using short of that to measure what is the impact that we're making. And I kind of like the yardstick of how many patients with myeloma are alive at 10 years. And it's encouraging to see that number has really gone up from the old days where it was a small number of patients. And both Ray Alexanian and myself, we published the results from MD Anderson in Arizona about the same time back in the 60s and the 70s. And it was about 10, 12, 13% of patients would live longer than 10 years. But now with the advent of transplant, it went up to around 25%. With the introduction of the new agents, it could be as high as 9 years median survival with current combinations with transplant. And so it looks like, there's no reason that we couldn't get to be in that higher percentage range. But I much prefer this as an endpoint versus the depth of the response. We already have 100% response rate with VRD, so that's not an adequate endpoint. And we have progression-free survivals that you've been listening to this morning, and these may or may not translate into an overall survival benefit. And this is true for both induction and for maintenance. You heard about Revlimid extends maintenance. What we're all waiting for is to see, will that translate into longer overall survival? And so that I would propose this as a way to look at our progress. And I'm now going to be anxious to hear our next speaker and your thoughts and discussions about how we put the pieces of the puzzle together and where we're going to be looking for our next piece for the puzzle. So I'll stop there. Thank you.